As we know that treatments have been emerging and new advanced treatments are here in Pakistan also, and we are going in a very fast pace. Understanding rheumatology is a little bit of a challenge as it involves all of the organs of the body. As the autoimmunity occurs, and this autoimmune process is occurring everywhere, not only targeting a specific organ, but its inflammatory markers are also getting its effect on rest of the body. So, as the previous talks were highlighting the apex of advancement, state-of-the-art lectures, I will try to discuss the relative gaps which we come across in our diseases treatment. So I will start my talk. So I have no disclaimer, and outcome of my talk today is basically to understand the gaps and trying to emerge the themes in our third world country and how to cope with them. Outline will comprise of all these topics. So how patient preview autoimmune diseases when they have. When I searched out the literature, interestingly, I've seen that a lot of autoimmune diseases were not there in the qualitative studies, and rather autoimmune diseases like SLE and rheumatoid arthritis was mainly focused in the studies. So what the patient think about autoimmune diseases and how they view it. As they come to the doctor, what they are doing is switching medications. And we have to counsel them that whether they are work or not, we do not know unless and until they are going to take them. Then, due to autoimmunity, as it is circulating all over the body, in the blood vessels, creating constitutional symptoms of constant pain, fatigue, fever, loss of appetite, as well as weight loss. So they are quite a lot in physical stress as well. Then slow effects of the medications leading to slow plan of dose change. So whenever we start our medications, especially the disease modifying agents, there are certain time which is required for them to act. We cannot increase them unless and until we have that effect in that specific lag of time. And in the meantime, the patient usually complains of the above symptoms of constitutional symptoms. Then there may be very effective, but the patient starts to have side effects like gastroenterological acid peptic disease, not tolerating, some liver function tests are being disturbed, renal function tests are being disturbed, as well as it's a very long course of disease. And interestingly, these all autoimmune diseases are basically having endogenous rhythms. What is happening? The patient is fully controlled on a certain treatment for quite a long time, and suddenly it deteriorates. So autoimmune diseases have their own endogenous rhythms, so that has to be tackled, and patients see them like that. Then there are certain personalities regarding their intent to treatment. Then we have biological treatments for the last 2 decades, and since 1 decade, since after 2010, I would say 2007 and 8, we have the first biologics introduced in Pakistan. So these all has so much to offer, so much load of information, no doubt for the doctors, but also for the patients. So whatever the discussion is that when to start them, when not to start them, when to switch, is taken up very in a concerned way by the patients. Then age and the level of intent for treatment. Usually these autoimmune diseases usually occur in young age groups, and as they get aware of their disease, they have a very long way to go, so they become quite apprehensive and concerned. And as well as whether they want to fight with it or whether they make peace with it by treatment. And then all the treatments, including the disease-modified drugs, as well as in the meanwhile giving the rest of the end organ management drugs, there is a huge inconvenience for the patients. Then self-doubts. There are a lot of self-doubts, like especially in our part of the country, where we have to give full-fledged counseling regarding disease, its treatment, its drug modalities, its side effects, its effects. So whatever we say, they always have doubts. So having all above emerging themes regarding patient's point of view, they do right decisions with wrong outcome. They are overwhelming dosages and schedules, so they try to self-trial changes in dosages. Sometimes वो कहते हैं कि जी ये दवाई हम कम कर देते हैं, वो ज़्यादा कर देते हैं. There are certain social taboos, stigmas which come in across. I'm going to discuss later in my next slides. And when they are better, when the disease is controlled with the disease-modified drugs, what they think that the disease likely has gone, so we should try to stop these two drugs. And we know that as the level of these drugs reduces in the blood, the disease usually relapses. And then there is a thinking process that it doesn't matter if I take a break, as I am feeling fine. Then comes the character of the disease. I have said that they have endogenous rhythms. RA, for example, rheumatoid arthritis, has a very diverse sort of a symptomatology, starting from just mild arthralgias, joints in the pains, not getting inflammation there for a while, coming and going. So, as well as sudden onset of symmetrical, the patient is absolutely not ready to accept that they are having these problems. Then they start to do incorrect interpretations, and age attributes a lot. Elderly as well as level of education counts a lot. Then there is misunderstanding about the problems. And then self-belief in the end, as I've already discussed. So all these features lead to a delayed diagnosis. And what the rheumatologists desire, they want to keep the patient under control so that we can save the end organs and save the patient from disability. But the patient takes the decisions emotionally. They are tired of taking the pills, they need a break. And once the drug is working, what they do is they start to forget the medications. And they want, interestingly, as we know that our prescription is full of drugs, so multiple times they have to plan their commitments around that prescription, and it is very difficult to plan like that. So then another thing which comes in is drug side effects. They have heard from their colleagues or the other patients which are facing and being treated for the same disease. They have read from the internet nowadays. Then apprehensions of the learned. What they do is they read the side effects from the leaflets and come to the consultant and the doctors asking about the questions that why this has been given, that these side effects are there. So we have to tell them that there are risks as well as benefits, and we have to weigh that ratio. So finding the right treatment, there is disappointment whether it will work or not, because we have to tell them, because there may be or there may be not a lot of switches in our treatments. Then there are constitutional symptoms which we have to take care of, as the patient must feel good, as the NICE guidelines also recommends that ease the patient despite of starting the treatment and despite the disease modifiers have started to work. And then the treatment switch lapses are very long. It's not before 2 months, 6 weeks to 12 weeks, 3 months that we plan to change our treatments or escalate the dosages. And the medicine working but side effects, again the same thing which have. And interestingly, treatment and responses are mismatched. As we know that disease modifiers start to act slowly, and as their effects build up, the patient requires response immediately. Then another stage actor regarding the gap is the depression and mental health and emotional health. Young age and long-term disease, I have discussed already. Diagnosis, change in treatments cause grief to the patient. They have to come, they have to go, they have to plan, they have to get the blood testing, then they have to sit in the long queues, and then they get checked. and then again starting to treatment without a confidence that whether the drugs will work or not. And when the treatment works, again they start to forget to follow the management plan. Then there is social stigmas. इसका कोई इलाज नहीं है, माजूरी हो जाएगी, ये तमाम इलाज बहुत ख़तरनाक हैं. So these all things are interpreted by the social factors. The best promoter to a drug compliance as well as mental health is the effect of the treatment. As it comes, the patient is happy. Another thing is they must meditate, concentrate. Self-awareness that best treatments are being given, and with acceptance comes peace. And they must know that they are not alone. As just Professor Tafazul has said that there is 4% of autoimmune diseases in the world. So regarding Pakistan, it's nearly 13 million patients at present. So who are the stakeholders to direct towards filling and reducing the gaps? And they are all these: patients, healthcare system, society, administrators, lawmakers, government, and politicians. It's not solely the responsibility and the holistic effort of the doctors, but it's holistic effort of the whole society. Now I'm going to discuss a few studies. I'm only going to give you the conclusions of those studies, which will give you how we are going to emerge the themes regarding how the gaps in autoimmune disorders treatment develop. Interestingly, I was just going through the literature, and I came to know that South Africa has been just given the status of a developed country. Prior to that, it was a upper middle income economy. And in that economy, in that developing country, it took nearly a year for the patients to start the treatment of rheumatoid arthritis. And rest of the developing countries, we must have some idea by now. In developing countries, there are very few studies, and there was a study in which there was a comment that might be there in Africa, there is a low prevalence, but I think so it's a lack in data. Then the local picture, a study was done in 2 hospitals in which RA treatment was being monitored, and it was seen that 1/3 of the patients left the medications, and another third had a poor compliance to it. And depression was quite prevalent among them due to unemployment, disability, and lower level of formal education. So this is another study which was done in, I think so, in California, and they also saw that in treatment of these disease, there was a lag of nearly a year of starting the treatment and 9 months on seeing the rheumatologist. Then another study from India, it was a qualitative study, and they have asked the patients regarding their symptom awareness, their interface with the health system, as well as how they give the recommendations. So they give a lot of recommendations that they needs to be improved. Then private versus public sector. In public sector hospital, they also did a study that whether the private sector is on a fast track, but it seemed that it was of the same duration as of the public sector. Then there was a study in 2011 regarding the socioeconomic determinants of disability and depression in patients with rheumatoid arthritis, and it also concluded that the social poor class was more prevalent towards depression as well as lag in seeking help from the health sector. Another study from 2014, it was done in Birmingham, from University of Birmingham, and they emerged 3 themes regarding lag in treatment, that there was a lack of knowledge of the first one there under the green headline, a lack of knowledge of RA symptoms, their individual risk of rheumatoid arthritis. Then there is normalization of symptoms, and they want to do self-management. They do not want to go to the Healthcare professionals don't want to waste their as well as their own time, a poor relationship with the family doctor. Then there is another study, components of treatment delay in rheumatoid arthritis differ according to autoimmunity status. This study was done in Newcastle in 2016, in which seropositivity and seronegativity was compared in duration of rheumatoid arthritis diagnosis. In patients who had anti-CCP antibodies as well as RA factor or either one of them, they were being diagnosed earlier, but we know that there are also certain individuals in which these serologies are negative. So it took a lot of time for them to being diagnosed as well as starting on the treatment. So on the part of healthcare system, it was also delayed. Then there was an Egyptian study done in 2020, and what they concluded that at the primary level, there must be awareness for the physicians, general physicians, to have a good knowledge of diagnosing the diseases. Especially this study was occurred in view of rheumatoid arthritis EULAR criteria of 2016. Then delayed DMARS therapy is effective in rheumatoid arthritis. This study was done at Aga Khan University in 2017, though it said that there was at the end of the 6 months the treatment of disease modifier was effective. But contrary analyzing it, it took nearly 6 months for a disease to get controlled on a regular compliance basis patients. So there was a monogram in a study which I wanted to share that first of all there are certain patient delay factors, then primary care delay factors, and then secondary care. All of them are likely overburdened, as well as patients' awareness regarding the disease, as well as the primary care physician not diagnosing initially. Then there were 5 constructs again, qualitative constructs. And what they said that early RA symptom experience was very much varied, so that also delayed the treatments and contacting the healthcare, making sense of early symptoms of the patient's experience as well as the typical RA picture. So when they compare with it, they see that it is not fitting it, so what they do is they usually defer it. Then minimizing the impact of symptoms, thinking that these symptoms are mild, they are not very much severe. Speaking to others, gathering information and seeking alternative treatments, and accessing health services towards healthcare professions is delayed. Then categories of illness representing and beliefs. I'm not going to go into detail of this busy slide, but as a cause, they thought that it is due to physical exertion, due to the aging process, due to hormonal changes. Then duration, it may be long term, it may be short term, it may come and go, as well as control of the symptoms can be done by the person, him or herself, as well as there are herbal remedies. So these are all misperceptions. Then it was also seen that at the primary care level, a study done in Catalonia, Spain, and it depicted that monographic clinics at the primary healthcare centers are also very much helpful in diagnosing and reducing the gap towards management. So the challenge, or a full house of challenges, what we have is a social representations and a public perception of the autoimmune disorders, misperceptions of the patient, and social stigmas, and individual affecting what he or she thinks about the disease. Then a few studies regarding the knowledge, how much knowledgeable is the public who are normal. In Australia in 2011, there was a study done on telephone about asking the types of the arthritis, and only 35% out of 2,000 knew about osteoarthritis, 44 about rheumatoid arthritis, and rest never knew about it. Male age group was absolutely mentioned it may be a general arthritis and not worried about it. And females and with high level of education income were aware of rheumatoid arthritis. And asked about the risk, patient thought that RA patients had accurate idea that any idea about the risk of rheumatoid arthritis. In USA, perhaps Dr. Shireen is sitting here. Farad Shireen is sitting here. She might give us some data also that 13% knew about rheumatoid arthritis and 28 thought that it is a natural process and perceived as a less severe type of an arthritis. In New Zealand, the students said that it's a non-life-threatening condition, and in UK, they thought that due to the weather conditions, the patient has arthritis. So emerging themes and gaps in the previous studies I've just suggested is that a socioeconomic status, a psychological effect of the disease. Professor Shakur is sitting here, and I'm hopeful that he will enlighten us on that. Awareness of the patient, fluctuating disease patterns, conservative self-personalities, misperceptions and experiences, serological interpretations, and patient-doctor rapport. Private and public sector involvement and their outcomes, primary care as well as family physicians, and demand response delay. These were the themes which emerge in delay in our treatments of autoimmune disorders. So, what could be the solution? Number one solution is health literacy, and what it is: obtain, interpret, and understand information. WHO has defined health literacy as the cognitive and social skill which determine motivation and ability to individuals to gain access, to understand, and to use information in ways which promote and maintain good health. And we have to build up a patient-centered approach. We have to empower the patient, what they desire, what they want. They must be the decision makers. Like just in the previous lecture, Dr. Tajwar was discussing about pregnancy in SLE. We have to give them the options. The patient has to choose it. But we have to tell to them, inform them what is important and what is needed for that time. Then they can control. If it feels wrong, must feel, they can make changes. They can contact doctors. Be honest to the doctor. And they have to make a goal in its treatment as well as in physical activities. And if it is not achieved, don't mind. Just discuss with the doctor for a change in the treatments. Then few words about how to avoid the drug side effect is taking it in the evening, especially the disease modifiers, on the weekends with the foods. There is anxiety before taking it. Think positive. You are not alone, and speak and carry on. And better to take medicine than to have pain whole of the week. And always surround the trusted and positive people. Regarding health care aspect, patient must partner with the rheumatologist. Compassionate doctors should be there. They must listen to the patient. They must tackle their queries and their concerns, and positive attitudes to the patients. So, how to improve it? There must be structured information to change the public perception of these diseases. There must be brochures. There must be leaflets around. There must be seminars publicly. Using medical names of the diseases. It's also been seen that we just use rheumatoid arthritis as गंठिया या arthritis का मरीज है. तो arthritis की एक typical picture society के अंदर उसकी definition मौजूद है. So we have to give them the name that this is a separate type of that is not the arthritis which socially they have heard about it. And then media attention impact is very much important. Unfortunately, media is influenced by sansani-khazi, like they are more to highlight the fatalities than the prevalence of a disease. So, when this happens, delayed treatments, worse outcomes due to lack of awareness, limited access to the healthcare facilities, low education, formal education, unhealthy diets, no exercises, smoking, stress, and a lot of, they have to come, they are at far-flung areas, they are difficult to reach tertiary care centers for their treatment. There is a lack of infrastructure, there is facilitative surroundings are lacking, like public transport, which is disabled friendly. Waiting areas are not present, access to drinking water is not there, and outside toilets are also not clean. But we know that we do not have a cure, but treatment strategies work. Newer treatments offer better control. Early aggressive treatment is the principle of since the last 2 decades, and awareness to treatment strategies, we have to give them this. Just think that if the symptom is gone, they are fine. We have to tell them that they need to control their disease. They do not need to control their pain. Control will be pain by itself as the disease modifiers start to work. Early diagnosis and early phase of the disease is the key to treatment. So early referrals, aggressive treatments, awareness through media, as we come across a lot of days of like psoriatic arthritis day in August, arthritis day in October, juvenile arthritis day in July, as well as rheumatoid arthritis day in February. So if we keep on highlighting these areas, people will be starting to perceive and get aware of their diseases. So in summary, the patient beliefs and awareness is pivotal, and health literacy is important. That has to be developed. Stakeholders are the key players, and steps have to be taken at every level, from patients to the treatment as well as home to healthcare facility. So never give up, and I thank you for listening to me, and I end up by quoting the father of the nation's quote, that if we want to make this great state of Pakistan happy and prosperous, we should wholly and solely concentrate on the well-being of the people, and especially the masses and the poor. Thank you very much.